The reason I love my Lyme doctor is because they listened to me. And I feel heard for the first time in my damn life, or at least since I got sick. But my question is, could you even hear them more deeply? Why does Neil Nathan love cranial osteopaths? Well, one, he's trained as one, but also we've got amazing osteopaths in the room. And what do? We sit down and we put our hands on people and we touch them in a way, not inappropriately obviously, but we touch them in a way that connects with their heart, with their true being. And I think that this is really one of the most important things for all of us to remember. So I wanted to kind of throw this in because what we're talking about at this conference is really just the beginning. I want you to really just know that when you go out and practice, we're all here for you. And so we're going to integrate all these things we know over time. But man, if we just take a moment to not make it so damn rushed, right? And if you look, I was just reading a book recently on people who are confident, right? And there's a lot of people in this room who everyone would say they're very confident. But what's the number one way that the public says someone is confident? Is it the loudest person in the room? Is it the most successful or the most best-selling books or the movie star? No, it's the person who is most comfortable. So as a clinician, as a parent, as a friend, as a partner, get comfortable with being in the moment and go for it and just relax a little bit because there's more science to talk about. So when we talk about tafenoquine, we can get two things. And back in the day, it was harder to get. We can certainly get really good cash prices at Amazon Home Pharmacy. But the two ways we typically get it are Aracoda in 100 or Cryptolepis in 150. And Cryptolepis has been on and off again, whether you can get it. So most of the dosing I talk about is Aracoda. And I just summarize different ways we could start. And I've done all of these with people of all different sizes. So, I mean, the most common, like we've talked about the most, is up top. But hey, maybe you have somebody sensitive, you just want them to kind of like, drift up a little bit. So you could do 2 tablets weekly. Or maybe you have a smaller person or a super sensitive person and you want to get that good kill going in the beginning, get a good therapeutic level, but you don't want to bump it up. Or maybe you read the paper and you go, I might not need that much. I could start here and keep this in reserve. And I would say for me, I would probably start here in acute Babesia infections, but I do a lot of this in the middle for other people. Do we need the higher doses? And this is why I talked about the pharmacology earlier. I haven't seen many people need to go above 300. Are there a few people out there? Absolutely. Is it something you may do? Sure. But this is where your methemoglobinemia goes way up and your hemolytic anemia happens much more frequently. So just understand that is one of the risks. So then I go, how the heck do I use this thing? Because as I said, the Babesia microti, unless you have a large amount of the infection or a virulent strain, you could use it alone, potentially. And then the other thing is they said you can eradicate microti and Duncani if you use it with atovaquone. Well, my question is, 1, that's acute, and 2, do we really need to? I don't know the answer to that because we haven't studied it enough. So one of my questions is, can I just combine a whole bunch of herbs with it? I remember back in the beginning of my career, I would take minocycline, and I would go like, hey, well, you have Lyme, and now I get your labs back, you have Bartnella. And they're like, well, I don't want to take any more antibiotics. I'm like, okay, take these 3 herbs. And they're like, sweet. And I just pretended those 3 herbs were my second intracellular. And it really helped me be able to sort of balance out these 2 different sides of things. So the question is, do we really need to use that combination? And we don't know. But we could also potentially use atovaquone and proguanil, which is Malarone. We could definitely use atovaquone and then do our traditional adding in azithromycin, despite the fact that we know from Dr. Ben Mamoon's lab that atovaquone and azithromycin do not effectively treat Babesia duncani, but maybe in combination with tafenoquine, especially if we're doing a Lyme protocol and a Bartnella protocol at the same time, we could start to build it in. One of my favorite things to do really is to take tafenoquine and add methylene blue to it. And one of the things, a couple things. One is I see a lot of kids, so I'm using a lot of lower dose things, and I often can't give them as much as like some of the talks that we had earlier where the protocols are larger, but adults can handle that. Some of the kids aren't able to, especially when they're itty bitties. But when MAPS challenged me to do, they said a couple years ago, hey Tom, do you want to talk about tick-borne infections, Lyme, Bartnella, Babesia, and then add in something on methylene blue? I was like, sweet, that's awesome. I do that all the time. I've got about 5 minutes on methylene blue, we'll be done. Turns out I signed up for an hour lecture on methylene blue. So, and I didn't think there was an hour on it, but apparently there is, because now doing 30 minutes on methylene blue is hard. But what I learned was, if you use lower doses in that antioxidant range, you find that methylene blue is really good at bypassing the first 2 respiratory complexes and dropping electrons into mitochondrial complex 3 while healing complex 1 and 2. So then I started going, I saw some people who are really, really sensitive to herbal protocols and medication protocols. No matter what everybody else did, 5 other practitioners, some of whom were in this room, they were like, look, I just blow up. I can't handle it after 2.5 weeks. I have to stop any protocol. And I go, you know what? I'm really good. I'm gonna do the same thing they did, but I'm gonna do it better. And of course, I fell flat on my face too. And then I was doing this lecture, and so I just said, hey, why don't we just start at 5 milligrams of methylene blue and see what happens? And this guy, for 8 months, his only protocol was 5 milligrams of methylene blue a day. But his energy levels were going up, his brain fog was going down, it was slow and steady, it was nowhere near, but it was the only protocol he had been able to handle for over 5 years. And then I bumped him to 10 milligrams a day, and then so I have 18 months now, and for another 10 months, and then we have 18 months of this low-dose methylene blue. About halfway through the second part, I had him do photoactivation on his belly. And then after that, we were able to do double-dose dapsone and get him up to 150 milligrams of methylene blue a day and blow through the whole protocol, and he's phenomenal now. I followed up with him like 3 weeks ago, and he's like, I don't have any Lyme symptoms. I've got a lot of stress in my life, and I need your help with that now. But it's amazing, sometimes we have to walk before we, or crawl before we walk, and walk before we run. So we've summarized a lot of this, so we can go super fast on this, some of the other work. But what's really interesting to me is Cryptolepis is better than doxy and cefuroxime. And it's the only thing that eradicates Borrelia burgdorferi forms and subcultures. So basically, Lyme doesn't grow back is what all this says. And then we have a really great work that was summarized earlier on Bartnella hensley with botanical medicines. And what's really interesting here is you'll see a lot of like Juglans nigra in here, and you'll see that I don't have that on a lot of slides because of nut allergies, but we certainly use it. But we saw eradication with Cryptolepis, black walnut hull, and Japanese knotweed for stationary forms. Another thing we can add to our protocols. Same thing. Before we even knew what to do with Babesia duncani other than clinically, we had Chinese skullcap and Cryptolepis. The bottom line is, this is the great triumvirate here, and if you want to add black walnut hull down here, you're going to be hitting the top ones and the bottom ones. So it's just really important to me, as someone who treats kids, this is an important way to think about things because I have to minimize things. And treating children and having to be judicious about what I've been doing really allows me to understand a little bit better about how I might be able to treat some of my adults who are super sensitive or who are just really non-compliant once I get above like 3 things. So then, again, could we take our tafenoquine and use things like Cryptolepis or Cryptolepis and Scutellaria? And I would say yes. Could we use our Artemisinin, either whole leaf or liposomal, which is one of my faves? Yeah, we can do those things. So we can add these and overlap them, and I find that that really helps a lot. And one of the things about the herbals that's so important in my practice is there's so many fringe benefits, right? These are things that are actually really going to calm down a lot of the side effects that you might have from your meds, so I put them together and use them in that way. I see Dan taking a picture, so just wait a second. So the question really with tafenoquine is where to start, right? And so like I said, probably in most adults I'm gonna start there. But then I go, hey, do I use atovaquone or do I use liposomal Cryptolepis? You know, I actually find liposomal Cryptolepis tastes a little bit better than straight up crypto, but they both taste like crap. So not that Mepron tastes any better, but just think about it. So maybe you can do this depending upon the severity, or maybe instead of versus, you put a plus in there, because I often do that. One of the things I always like, that I've always heard, and I remember Betty Maloney and I were talking about this, and with a whole bunch of other people in the ILADS Fundamentals working group at one point, one of the biggest things that people get upset about our field about is that we just put people on open-ended protocols without an endpoint. And one of the things I loved hearing today from everybody is like, there's a starting point, there's an end point. So we have a diagnosis, admission criteria, and then we're already planning to get off. And it's not like dapsone for 25 years, it's dapsone for 9 weeks, and then maybe a pulse additional, right? The herbs we're doing for a period of time. Nancy and Lindsay are saying, hey, your Bartnella might be about 9 months. At least start thinking about that, and then always follow up. It's always about, when I'm looking at what's going on in somebody, prioritize their symptoms, because there's no right place to start. Because if I talk to Rich and I talk to Mariah and Nancy and I call up Neil and then we talk to, Jeff or whatever, it's like everybody's gonna start somewhere different. And you and your patient have that unique healing bond, which is why I want you to really sit with them so you can resonate and know what those pieces are. But then once you prioritize it, do something, reassess it, and reprioritize. That's what we do in medicine all the time. It's like critical care medicine. You walk in and everything's good. 5 minutes later, the shit hits the fan, you do something different. It's no different, right? It's just, but this is one of the biggest things that we need to be doing. So, and then the other part, just a quick pitch for monitoring. I've heard Rich talk about it. I heard a bunch of other people this morning, yesterday talk about it. Taking a time off of treatment is not treating. Monitoring the effect of your medical approach, like the patient Rich was talking about, like, you know, oh, just stop and come back in 3 months. He's like, I'm amazing, right? And so just monitoring is an actual active treatment. So for this part, we talked about a foundation, and a lot of what we've been talking about the entire weekend, I would put here. We've got things like, hey, maybe with babesiosis, we need to add fibrinolytic or other types of enzymes. Just a plug for Borrelia. The Borrelia biofilm researchers say there's no fibrin in Borrelia biofilms, but fibrinolytics work, so let's find out why. Not use them because we told them that they had it in there. Although, and then Babesia probably is in fibrin, but we need to do more research. We should use our botanicals like we talked about, and all the co-infection treatments, all the detoxification supports, and then also, like, there are definitely homeopathics that can help your body remember this, but this is all the foundation, right? And so one of the things I like to do is say I play Lyme chess. I'm gonna make a move, I'm gonna see what the hell's going on, and I'm gonna see how that person's body and the pathogens they have will respond, so then I know what the next move is. And it's especially important in our children because they, like I've said, they get overloaded and they just want to see results. And I totally agree. Earlier, we were talking about like sending the parents to therapy. A lot of times that's the only place to start because so many of my parents don't do the work that they want their kid to do and they wonder why their kid's not doing it. I'm like, well, maybe you should do it first and lead by example. But let's find out, where do we have an inroads to treat? And then a lot of times, I remember talking with Ginger Savely years ago, it's like everybody has babesiosis. Even if you don't find it, you're eventually gonna have to treat it. And I'm like, well, maybe. But very commonly, yes. But how did she come to that knowing? Well, it's because she was making moves, and then the only thing left was like all of a sudden these Babesia symptoms came out as we unloaded and unburdened the immune system. So I always, suggest playing a little bit of Lyme chess.